Welcome everyone. Thank you all for attending tonight's event, Decolonising Healthcare. So I'd like to start by acknowledging the Kaurna people, the original custodians of the Adelaide Plains and the land on which the University of Adelaide's campuses here at North Terrace, at Waite and Roseworthy are all built. My name is Hayley Parkinson and I'm undertaking my PhD here at the University of Adelaide in the School of Biomedicine, and I'm going to be your MC for tonight. First Nations people experience chronic health conditions at higher rates and younger ages than other Australians. This is largely due to factors such as colonisation and racism. Aboriginal and Torres Strait Islander voices have historically gone unheard in healthcare, but researchers at the University of Adelaide are listening and taking action hand in hand with the community. Today you'll hear from two of these researchers, Professor Janet Kelly and Dr. Kim O'Donnell. Janet is a nurse researcher at the University of Adelaide and she co-leads the Action 2, an NHMRC Ideas grant-funded project that identifies strategies to improve First Nations kidney care. You'll also hear from Kim, the other co-leader of Action 2, a senior researcher in Aboriginal and Torres Strait Islander health at both the University of Adelaide and Flinders University. In addition to being an internationally recognised public health researcher, Kim is also a Maliang Apa Barkinji mother who brings extensive lived experience into translating research into practice. Please join me now in welcoming the two to the stage.
There we go. Thank you. Thank you very much for that acknowledgement. We too would like to acknowledge that we're meeting here today on the lands of the Kaurna people and pay our respects to elders past, present and emerging. We also would like to acknowledge that Kaurna people have a deep attachment and relationship to the land here, and we recognise the land, the waters and the air. We would also like to let everybody know that our presentation contains the name and images of people who have passed away, and we share their names and images with their permission and with the permission and the encouragement of their family members to honour their role as health warriors and to continue building the legacy that they started.
We in particular like to acknowledge and pay our deep respects to two of our matriarchs that we lost last year, have passed on. If it wasn't for the conversations these matriarchs have had prior to action starting, we certainly wouldn't be standing here. So these two amazing kidney warriors have been working and advocating in this space for a long, long time to, in particular, encourage collaborative, respectful work to decolonise the kidney healthcare area. So what will Janet and I talk about today? We're going to be sharing with you what we do, how we do it, and what we've learned along the way and are still learning. We're also going to be giving you pragmatic examples about decolonising the kidney healthcare space. We recognise that many people and services are also striving to provide quality, responsive care, and that there's still also a lot more work for all of us to do. Because we are certainly a part of a much bigger and larger, collaboration means the same, collaboration.
And we'll be using kidney healthcare examples, but we really invite you to consider how these might apply to your own areas of work, education or where you fit within society. So when we think about decolonisation, we thought a lot about a definition, and this is a definition that we've come up with together. Decolonisation is a process of acknowledging and addressing the ongoing trauma and impact of colonisation by European powers on the First Nations people of Australia and working together to rectify the wrongs. Last week, the Productivity Commission commented on Close the Gap. And Natalie Ziegel-Brown, the Commissioner of the Productivity Commission, said governments across Australia have largely not fulfilled their commitments under the agreement. They have not grasped the nature or the magnitude or the changes they promised to make. They are unwilling to relinquish control, are lacking accountability and have only tokenistic engagement with Indigenous organisations. Their actions don't align with what the community say will work. Programs are not measured in terms of what communities value as markers of change. They continue to allocate public money ineffectively. This is what we're trying to address. We're addressing it in healthcare and we're addressing it in research.
But we can't really address decolonisation if we don't know what the impacts of colonisation have been on the First Nation peoples of this country. So for First Nation peoples, we've been developing health, wellbeing and environmental research for at least 65,000 years. Research is built into the survival of our people for that time. Colonial scientific approaches to healthcare and research were imported and developed in Australia over 236 years ago, alongside colonisation and racist policies and actions. So they've largely ignored First Nation people's ways of knowing, being and doing. And in research terminology, that's knowing, epistemology, being, ontology, and doing, axiology, methodology. Many First Nations people have learned from experience to distrust Eurocentric healthcare and research over many years. This is where action works in the colony between top-down and bottom-up approaches to kidney care. So on the left-hand side, which is probably, yes, on the left-hand side.
I could do the little
Thank
thing.
you, Janet.
There we go.
So on the left-hand side, we work in the colony between the top-down and bottom-up approaches to kidney care. We hold the space in the middle, this project, for respectful yet challenging conversations where egos are left at the door and kidney patient experts are central to our research actions. The decolonising processes, that's our hope, to flatten and disrupt the hierarchy. Right now, we have a window of opportunity alongside effective allies in positions of power that are willing to have a crack, to step outside their comfort zones, to walk with patient experts and carers in a process of solidarity for improved anti-racist care that's culturally safe.
So when we're looking at the project and looking at what we're doing in kidney care and Aboriginal healthcare, we're often working in the brave space. So that space where First Nations health and wellbeing and First Nations people's experiences of healthcare come together, and how do we create this space where people feel safer? So for many First Nations people, the collective decision making is really important, and inclusion. There's a really important connection to spirit and to spirituality, to ancestors. Family and community are really important. Kinship ties are really important. Connection to country and to culture. And not just separate body parts, but the body, mind and spirit all being together. And life, death, life cycles. When we then move across to the other side, when we think about the way we've structured our hospital system in the Western health system, we've got a lot of autocratic top-down decision-making. We kind of have a one-size-fits-all that doesn't actually work for all people, and particularly doesn't work for a lot of Aboriginal and Torres Strait Islander people. Often there's a lot of disconnection that people experience because there's a real reliance on the biomedical and the physical. If you think about how the Royal Adelaide Hospital is structured, it's all in body parts. You go to different wards and units to have different body parts, but what happens when you've got a range of different chronic conditions that involves lots of different body parts? And actually you'd rather be home and there's some other important things happening, but someone's just focusing on what's happening with this one body part. So that separation and the focus on the individual rather than on families and communities can often lead to a real disconnect and a real tension between those caring for and the way our system positions people and what it is that Aboriginal and Torres Strait Islander people would prefer in having healthcare and to have health and wellbeing. Our health system is also very much focused on the city. If you think about particularly South Australia, we're very city-centric. But about half of the Aboriginal population live in rural and remote areas. So what does that then mean for people, particularly when they have care that needs healthcare needs that require specialised care? The other thing is often we'll have short-term funding cycles. So something might be set up that's working really well, but then it will change again. And then, the next time something's set up, people are a little bit more distrustful and unwilling to engage, because how long will that last for? So these are all things that can really interrupt healthcare. If we can come together, build trusting relationships, have two-way respectful conversation, have shared decision-making, for those of us who maybe are used to working in the Western hospital system, thinking really critically about the care we provide and how we can change things a little bit so it can provide the care that people are requiring, and see if we can embed these in so we've got some longer term care solutions.
So this is Action. Action is a name that we came up with, well, particularly a reference member came up with it. She said, we just don't want all talk, we want to make sure that this work leads to actions. So we've called it the Aboriginal Kidney Care Together Improving Outcomes Now project. So let me explain, using the Action project as an example about how we work and how we do the smaller things to help decolonise. So the aim of Action is to improve the experiences and outcomes for kidney care and with Aboriginal and First Nation patients, families and community members, and also the health services in South Australia. So we're going to talk about kidney-specific care, but we also invite you to consider these aspects in your work or wherever you may work. It could be in education, it could be in council, it could be anywhere really. So we'd like you to have a think also about the ways that you can work. That could be a bit more decolonising.
Enough colonising
enough
happening.
of that.
So why are we focusing on kidney health? Well, unfortunately, First Nations people experience disproportionate levels of kidney disease. And this is happening in the city as well as in country areas. Aboriginal and Torres Strait Islander people are 4 times more likely to develop kidney disease and 4 times more likely to die from kidney disease. And tragically, this often happens at younger ages. In some rural and remote areas, the incidence is up to 20 times higher. So for us, that raises questions about what is this saying about ongoing impacts of colonisation? What is it saying about the policies and decision making? What's happening for people, particularly in rural and remote areas, around transport and distance? Why are the rates so much higher in rural and remote? What is it about access that's highlighting for us? What's happening around health and wellbeing? What's available for people? Do they have secure housing, water, food? And what's happening in the primary healthcare services? What's happening around our preventative healthcare and early detection? And are people being treated for things like infections to help prevent kidney disease? Is diabetes being detected early? People are being supported to ensure that the diabetes, the heart disease, the kidney disease aren't progressing quickly. There's things that can be put in place to slow things down and to prevent, and are people having access to those? And what's happening with kidney care? How much kidney care is provided outside of the CBD versus inside of the CBD? So when we started the project, it was really important that we started by going to community members and asking what was important for them. So here's one of the community consultations. We went to Port Augusta and Ceduna and also here in Adelaide. And here's an example of how we do decolonising research and that we can find out from community what's really important for them. So this picture tells a lot of a story. So here we have Roxanne Sambo, who's an Aboriginal health practitioner. It was really important that it was Roxanne standing at the front of the room talking to community. She's related to a lot of people there. They know her. There's already a trusting relationship there. She could explain what we were thinking about with research and ask people, what was working and not working from their perspective in a way that myself as a non-Indigenous nurse wasn't able to, and Kim didn't have relationship in the same way that Roxanne did. So it was really important that it was Roxanne. We have Sue Crail, the nephrologist, the kidney doctor. She's taking photos. Her role was really important in the clinic, but in this setting, she was there to listen, to hear what was working for people and not working for them. And Tali here, the lovely Tali, was taking photos and recording things. So Tali, as a nurse and researcher, was there to be supporting, to writing up, to take photos, to record, so we could take the data back and pull it all together. Here, that's the CEO of Kidney Health Australia. That's Chris Forbes. He came to listen. What was really important was he left the East Coast, he came to Port Augusta, and he sat and he listened to people. And then listening, experiencing, hearing people's stories was incredibly important. Here is our matriarch, Ina Winchie Williamson, who's no longer with us. She was interpreting, and I could interpret in a few different languages, so she was interpreting to the women. She was not only interpreting words, she was also interpreting the meaning and experiences, because she too has kidney disease. So then what Roxanne was saying as a health practitioner, and then Ina Winchie could talk about it from lived experience. So this is one of the approaches that we take. Lying down here is an old dialysis machine, and Ina Winchie is painting her kidney journey on the dialysis machine, so that then that can be placed into a primary healthcare centre, so that people for whom English is not their first language can read Ina's journey story, and then they might choose to ask for having some tests to check if they've got kidney disease.
And it's also been taken into the schools too, to talk about prevention of kidney disease and to keep children and families off the machines in the first place. So it's been a wonderful resource to take into the schools as well.
The other thing that happened is, from what everyone shared with us, we shared that with the local health services so it could have a local impact. We also shared it, we brought together what people were saying in Ceduna and Port Augusta and Adelaide, and shared that at a state level, so the kidney health services could look at how they could respond to the gaps. It also then went up to a national level, because we're working on the new national clinical guidelines, the first ever set of guidelines specifically for Aboriginal and Torres Strait Islander people. So people's voices from rural and remote as well as urban areas of South Australia could inform national policy.
So Action is based at the University of Adelaide in the School of Nursing in South Australia. It began in 2018, supported by a 12-month Medical Research Future Fund grant. This grant was extended in terms of deliverables due to COVID-19. The project was overseen by the Action Reference Team, consisting of Aboriginal people with lived experiences of dialysis and kidney transplants, including family carers. The second stage of Action is funded by a 2020 5-year NH and MRC Ideas grant. This 5-year funding injection enabled Action's scope and collaborations to expand considerably and to influence changes in the kidney care space. There are 4 nested sub-studies. Firstly, Indigenous governance. Secondly, kidney journey mapping, as Janet's mentioned before. We've developed resources and tools for clinicians. Support for kidney patients and the carers, and that's in terms of resources that are yet to be developed. And also cultural safety in kidney care. So that's also having influence on developing the curriculum and teaching new health professionals in this space as well. And finally, our end goals are at the bottom there of the screen. So it's better kidney care, dialysis, transplantation, access, as Janet's mentioned before, education and prevention. It's also cultural safety training and effective partnership with an Indigenous workforce. And for the health services and systems around influencing policy also, it's improved coordination guidelines and standards informed by community, hoping to reduce racism.
So how do we go about doing this if we put our research lens on for a moment? Now, often in nursing, we'll do a plan, do, study, act, review. Fantastic for ED, emergency department. Someone comes in bleeding, plan, I'm going to get this, I'm going to do it, did it work? Okay, if not, so, bleeding, bandage, Stop bleeding, no, more bandage. Works really well, really clear, action, need to do it. When we're working in decolonising research, the kind that we're talking about, I could have a great idea as a white fellow nurse, I'm going to do this. I could go and do it, and then I might go, uh-oh, that didn't work. So a much more effective way, and a much more collaborative way that the women from Gillis Plains, back when I was doing my PhD in 2008, and we were working together, we've been working together for a while, they were saying, yes, there's only stringers look, think, act, but it's important to look and listen. It's important to think and discuss together. It's important to take action together and review effectiveness. So there's also Aboriginal methodologies that can help inform us. So in the look and listen, it's the dadri, the deep listening. You're listening really deeply with the head and the heart. What is someone saying, and what are they saying even though it might not be in words? What is really important for this person? The Gamma knowledge exchange, two-way knowledge. How do we bring together Indigenous and non-Indigenous knowledge and share it together in respectful ways? And how do we have a yarn? How do we have those respectful conversations that might take a bit of time? How do we do that? And the collective action. What collective action is needed and what is meaningful? And who does what? And which bits do we do together?
So there's 4 areas of research. Indigenous governance, as I mentioned before. This comes from one of the reference team members, actually. We are more than our disease. What she was expressing there was, we just don't want to be seen as having, renal failure, kidney problems. We have much more to give. We are much more than our disease. In support for Aboriginal kidney patients, their words was, we know what it's like. We know what it's like to go through that process, to be on the machines, to have a transplant. No one else should have to experience what they've experienced. So they're talking about trying to prevent other people and community people and others going on the machine in the first place. And sometimes they just don't get it. They, meaning the health professionals in the hospital, they just don't get it around how to make Aboriginal and Torres Strait Islander people feel safe in that place. So again, as we mentioned, it's important to improve the experiences and outcomes of kidney care for and with and alongside Aboriginal patients, families and the community members, and in particular to influence kidney health services in South Australia to in terms of their policies. So this is the team. This is the original reference team. And I came on board I think maybe 2 months into the first 12 months of funding. And it was important that the work that we were doing was influenced and directed, and with that we centred the reference team members. So I came on board to set up and establish the reference team.
And what was really important is that Kim did come on board, because when we first started the project, I was leading the project, but I was missing something. I was missing something big time, and I'm going, it isn't working. I actually need to be working with Kim and say, Kim, are you free? Come and work, with me, because I knew that if I just tried to lead this project, it just wasn't going to work.
This is the National Indigenous Kidney Transplantation Task Force. It's a mouthful. This gathering, in collaboration with the NICT, happened end of last year, I think it was, end of last year. And this gathering brought together Aboriginal and Torres Strait Islander people from across the country and their carers. It brought them here to Tandanya in Adelaide. And this collaboration came from what Aboriginal families had wanted at the first gathering, which was held in Alice Springs several years prior, but was very much clinical focused and was very much led and run by clinical health professional and staff. So they wanted a gathering where their voices could be elevated, where they could be heard, and where they could have a say in how they wanted to meet what it is that they wanted to prioritise. So this gathering was facilitated and chaired collectively by Action Reference Team members who are now Chief Investigators of Action. And so we also worked, so it flipped the leadership, I guess, and the power within the room to having the conference facilitated by 4 Aboriginal women, not only the chief investigators and leaders that have had transplants, but also working alongside Jackie Hughes, who's doing some amazing work, and she was our first nephrologist, Torres Strait Islander woman, which Janet will point to. Is she in there? Yes,
yeah,
she is.
She's there in the green.
So how the health professionals could help and work with us was to ensure that all the members that came from across Australia had access to dialysis here in Adelaide. So they stepped aside, enabled Aboriginal and Torres Strait Islander leaders, and particularly women, to lead this whole conference, to facilitate it, to engage with mob, and to ensure that their voices were heard. At the same time this was happening, we had a part of our team that was racing off actually here to the Bragg Centre to receive an award, and it was the University Award for Outstanding Achievement and Excellence in Research. So on the one hand, we had all this national mob in Tandanya, and then we had another group coming over to receive an award in research. So that was quite moving for all of us in terms of collaboration.
And we were running up and down Frame Road with Nari in the wheelchair, so it was definitely moving on a few different levels.
Certainly was. So peer support. So originally we were planning to conduct a small patient navigator pilot project as part of Action, and then the peer navigators are are Aboriginal people with lived experience of kidney disease and kidney transplantation. So we wanted to pilot positions within the hospitals and the healthcare system with peer navigators, so that when Aboriginal people are coming into the hospitals, the first person they would meet would be a peer navigator who has lived experience of being on dialysis and also of transplant. So what happened was NICT, the National Indigenous Kidney Transplantation Task Force, and collaborators with us put in for some funding. So they shaved off that part of piloting patient navigators, and now that's become a bigger project which sits under NICT but is still in collaboration with Action.
And that goes across the backbone of Australia?
Yes, so we're collaborating from Darwin down to Alice Springs, back down to Adelaide.
And Port
Augusta. Mm.
The other thing that we've been doing is kidney journey mapping. So you saw there's the dialysis machine that Inna was painting with her 2 nieces, painting her journey story. She also painted her journey on the first picture on the left there, which tells about her kidney journey, and it talks about coming from the desert, and in there you'll see the desert flowers, and then about coming together and meeting with other people and with health services and receiving dialysis in the city. So these are ways that community can share their journey stories. It's another part of that peer sharing, peer teaching. And then Rani Lester, who's another Aboriginal woman in the team, who's Chief Investigator and Reference Team member, and also peer navigator, she also uses sand mapping, sand trace, and actually this is her journey that she was happy for us to share, that tells her story of her journey map. At the same time, being that we're recognising both Aboriginal preferred ways of knowing, being and doing, but also Western research, because we need to operate in both spaces, what we'll do is we'll also write in depth within words about people's journey stories, and we'll bring them together and we'll analyse them, and then we can compare them against the Indigenous guidelines that community helped write to the priorities that they set. We can also compare them to the national quality and safety standards that hospitals and health services use and are accredited against. So there's 6 specific guidelines for Aboriginal and Torres Strait Islander people. And then within the more broad quality and safety framework, it fits really nicely with Standard 2, which is partnering with consumers, Standard 5, which is comprehensive care, and then Standard 6, which is communicating for safety. So part of what we do is that we bring together community members and hear what's important for them. We bring together health professionals and hear from them what's working and what's not working. And we bring them together so they can have different conversations with each other. And then we look at what are the levers around, what are the guidelines, what are the standards, how can we work together? How do we help kidney health professionals to themselves have the levers and to work within the system that's often really clunky to provide more wraparound and responsive care for people? Because often people are really wanting to, but how can you, and which part do you focus on first? So the journey mapping really helps us to identify which are the key points that are most troublesome for people and where might we start. So it can be very useful for that. Next one. We're also doing a range of things around cultural safety. We teamed up with the Loitry Institute as part of the National Indigenous Kidney Transplantation Task Force to do the cultural bias literature review, which ended up being a report and policy brief. And this is another lever that people can use to ensure that they can provide the most responsive care possible. In there, we were able to tell some of the experiences that people have and how this impacts their care. And some of these things aren't generally found in the literature because maybe people aren't talking about them. So Kelly Owen, who's part of the team, who's the national coordinator for NICT, she was able to go and have conversations with people and talk about their experiences as someone who herself has lived the experience of kidney disease, talking to other people around the country. We've also been embedding cultural safety into the national clinical guidelines. There's one of our nursing lecturers in our school is doing her PhD study, Melissa Arnold-Ajavari, who's looking at the emergence of cultural safety in kidney care, which is really important. She's been a renal nurse, and so it's really important. She can have conversations with renal nurses and, you know, what's happening and how do we improve things. Then there's also the task force that Kim spoke about. And there is a new Decolonising clinical care course that we've co-designed with staff at the Carlin that's currently being trialled at the Royal Adelaide Hospital. Yep.
This is we think this may be a first. So we've been very lucky to be able to work with Gangawadli staff and establish dialysis chairs at the hostel. And the dialysis chairs are there, and they came from people who said we get lost when we are expected to go into the Royal Adelaide Hospital, and we need a place where we feel safe and where we can have dialysis and have other wraparound services as well. So the Gangawadli chairs are a success. We've started off with 2, we now have 3. It also included an evaluation of those chairs, and we know it's not a one-size-fits-all, and we also know that it's important to be sensitive to community needs when we're working in this space. So I think that's about it.
Do you want me to give a bit of backstory?
Yeah.
So for those less familiar, so when people come from Aboriginal people come from rural and remote areas of South Australia, if they need to come down for care, and it might be, you know, they're just having a one-day treatment, or it might be a few weeks, a series of things, or a few months, they need somewhere to stay if they don't have family. You know, accommodation's so expensive, as we know. So Gangawadli is an Aboriginal hostel. It's actually the only one in the country that's run by SA Health. Or by health service. So it's an accommodation service, but also has a health focus. So many people would stay there, and then, as Kim said, you know, they would often get lost and they'd miss their dialysis. People have dialysis 3 times a week, and if they miss more than 2 days, they start to get really unwell. The body starts to overload, they start getting breathless, they start, fluid build up, and people end up with emergency admissions at the hospital. So this came alongside, so the staff at the dialysis services. We're also worried about emergency admissions that people were having at the Royal Adelaide Hospital and the Queen Liz. And they're really concerned about what was happening for the people involved. They were, ambulances were ramping and people were going in and checking how many of those were renal patients and getting them straight up to dialysis. Like, it was serious. At the same time, community members were also identifying it. So we brought those two together and then went, okay, what could be a solution? The other thing with Inaction that's been really effective is that we have decision makers and power brokers as part of the action team. So we've got the Aboriginal people with lived experience of kidney disease as the chief investigators, and we've got a lot of other people as associate investigators who run health services and make big decisions. And so we're able to say, right, is it possible to get some dialysis machines in the hostel? And then they're able to work out how that could happen.
And two of the issues that this addressed by having the dialysis machines there was transport and accommodation, because the hostel had a bus. It also had the accommodation where people could have dialysis and feel safe and stay there as well. This hostel is surrounded, it has a fire in the middle, so it's culturally safe for people, and they can also have their family members come see them in that space. So it's kind of like going back to the 80s where the services used to go out to the people and then the services were withdrawn. So rather than expecting the people, as Janet says, to travel to healthcare, let's go back and circle back and take the healthcare to the people like it used to be.
So one of the other areas that community have expressed real concerns about, and so too have the kidney health professionals, is oral health. So as we know, it's quite expensive to go to the dentist. And when people are doing workup for kidney transplantation, there's a series of tests that people need to have. One of the one that's often the real blocker between someone actually getting on the transplant list and not is dental care and oral health. So we looked at a couple of different ways. How could we help to get access to oral health care? So we teamed up in the end with TAFE SA and with the oral dental hygienist students. And so now what we have is clinical placements, so that students come in, they come to Gengawadley, you can see the fire pit there outside, they'll come and they'll start having conversations, and Margie, who I think I saw come in, is, the lovely Margie, is been a real powerhouse in helping this get going. Margie has all these connections. So that's been really important. So students are coming in, they're meeting people. Over time, they're starting to have a conversation about oral health. We're also doing cultural safety training with the students before they get there. So we're looking at how do we think outside the box? How do we bring things together? How do we network together? How do we embed this? This project, this action project is going to finish in 2 years. How do we ensure we've embedded things that live beyond the life of this project? Because we can't just have the project and go, we've got to embed things. That's part of decolonising.
So here's another example of an activity that we could influence and do, and it was an organ smoking ceremony. It was the first to be had at the Royal Adelaide Hospital, and the Action Reference group was certainly instrumental in influencing this to happen, and to hold the organ smoking ceremony as part of healing also for the kidney transplant patient, who was a young 17-year-old Ghana Ngarrindjeri Naranga adolescent. He received his transplant and also at the same time he also was successful in finishing his Year 12 studies as well. So this organ ceremony happened now probably a couple of years ago. And we're hoping that we can have more and actually embed ceremony and bring ceremony into research and bring ceremony that's going to be beneficial to all people to try to rehumanise the healthcare system.
And part of that connection up through the backbone of Australia that we're talking about is that for people up top end, smoking isn't always the cleansing way that they prefer. It might be water. So there's lots of negotiation as well. You're not making the assumption that all Aboriginal and Torres Strait Islander people have the same ways of expressing culture, that there might be differences as well.
Exactly, and also understanding that maybe not all Aboriginal people will want to have a smoking ceremony. They might want to do things differently.
The other things that we've been doing is going out to Ceduna and Yellowta. So we had the Kidney Yarning Festival in the town hall, and as you can see, Billy the Kidney came to Ceduna. Billy the Kidney ran up and down the main street and kind of encouraged lots of people to come in. So that's a real alternate way to do the health promotion and community awareness around kidney health and what kidneys are. And then we also went to Yellowta with the Health and Medical Science students, part of AURA, the Adelaide University Health Rural Alliance. They go there every year, and they go to the primary schools. The kindy, the primary school and the high school in Yellowta. And at the same time, we negotiated to bring the kidney bus, so that then you could have the children learning about kidney health in the schools. Then you could also have the grandparents and the parents coming back on the dialysis truck, and then you could bring this all together. So that then helped us to enact some of those guidelines. That was really important. We've probably covered that one if we're short on time.
Mm-hmm.
Yep. And so now if we do it again. So we're going to show a video now, and this does have community members who have passed in the video.
This is our journey. Walk with us. Can you hear us?
This is our journey. Walk with us.
This is our journey. Walk with us. Can you hear us?
Family, my kids, my grandkids all keep me going.
My music keeps me motivated and keeps me at peace.
My family, country and culture, part of my care.
When you sit down and have a yarn with me, it means you can understand my pathway and my journey, and it helps me to stay strong and healthy.
We live with this disease forever. We need support, care and understanding.
Accommodate for everyone because we all can't walk.
My family, my culture, my country are part of my care.
We always set aside and watch the stars.
Train our people to care our way.
Beautiful stars.
Dialysis is my second home now. Help me feel safe.
And I miss the stars.
Being on country, being treated our way with our families around us.
It means I can hear you and you can hear me.
We notice the lights, sound and smells in the facility. Sometimes we need the lights turned down.
Help stop our young ones following us, getting onto the machines.
These are our stories. Walk with us.
Walk with us.
Walk with us.
Walk with us.
Walk with us. This is forever.
So one of the things that was really important was that the final piece of starting the community consultations with community, taking the information, writing the guidelines, taking them back, ensuring they were what community were prioritising. And then for community members, people with lived experience, to actually then be part of the knowledge translation and to speak from the heart about what the guidelines actually mean.
So what have we learned and what are we still learning on this journey? We're learning that it's really difficult to do research while grieving because we lose lots of family and friends and colleagues, not only patients or not only our colleagues that have had transplants or were awaiting transplants, but also generally amongst our staff, Aboriginal staff. There is a constant funerals and services to go to. And that's a lot to hold. That's a lot to hold and still function in terms of trauma. So that's certainly been conversations I think that we've had and we've certainly are having, and it's certainly an area that we're writing about. Also, what we are learning is when is it time for health professionals, non-Aboriginal people to just step aside? When is it time for them to share that space? When is it time to step back? When to know when to step forward, step back, assist, help, and to walk alongside each other. We want to have collaborations that have impact, and we certainly don't want to duplicate because there's enough of that going on. We certainly want to make sure that we can break down the silos in terms of how the funding's structured and how organisations and the health system can work. We are able to share resources with our collaborators and make collective decisions together, because we understand that competition and the way funding is structured, competition's good, a little competition, but we also know and have experienced how competition can divide people and resources, and that's certainly not what we want to do. So we spend a lot of time to gain respect. We spend a lot of time to build relationships because we know that time plus respect equals trust, and we know that from lived experiences, governments shift the goalposts constantly for us. So it's really important to really embed an emphasis on building those relationships with health professionals and across communities and across the organisations we work with. And we don't call working in the way we do safe. It's not a safe space. It's never a safe space, but we certainly refer to it as a brave space. And we don't always get it right, but we keep trying. So I'd like to now leave you with this poem, an invitation to a brave space that I hope can give you something to think about, something to consider, something to reflect on in terms of this work. And we've just been able to show you what we do in this renal space and with our collaborations, but we'd like you to think broader in terms of social justice and other areas across this country. Invitation to a brave space. Together we will create brave space, because there is no such thing as a safe space. We exist in the real world. We all carry scars and have all caused wounds. In this space we seek to turn down the volume of the outside world. We amplify voices that fight to be heard elsewhere. We call each other to more truth and love. We have the right to start somewhere and continue to grow. We have the responsibility to examine what we think we know. We will not be perfect. It will not always be what we wish it to be, but it will be our brave space together, and we will work on it side by side. And that's a poem that when we get to deep conversations about relationships and working in this project, we come back to remind ourselves of this brave space that we are in. And that's a poem by Mickey Scott Bayer, who was inspired by Beth Strano for that. So that's what we come back to. And on that note, Miss Janet, I think we're finished. Thank you for having us.
Thanks so much to both of you. That was really fantastic. For me as a non-Indigenous person, that was, really insightful. And really highlighted the important work that you guys are doing. And I really hope that one day we'll be able to close this healthcare gap, not only in kidney care, but in care in general. So thank you both for that. So we'll now open up to question time. So if anyone in the room has any questions, just pop your hand up and one of our roving mics will come down to you. And also if you're listening online, you can submit a question in the Q&A box at the bottom of your screen. So we've just got one question here.
Thank you. You mentioned that in the hospital or in the care facility, there is the intention to have an Aboriginal person welcome those who are coming into care to help create a a sense of comfort. Given what you said that one group like a smoking ceremony, other groups prefer water, etc., how is it that one Aboriginal person can find a common denomination or common denominator that can go ahead and help everyone that comes in? Is there such a thing? And how is it that that person from one particular community can help all others coming in? It's something I've often wondered about, not just in healthcare, but in trying to find a common voice.
So I'll try and answer that, but I might draw on Kim as well. So from the stories I hear, often people will say that when they're in hospital and there's just a whole range of people there and a whole lot of white faces, that sometimes they'll see an Aboriginal person and go, thank goodness there's an Aboriginal person here. So sometimes it's someone who's more familiar, someone who might understand that things are uncomfortable, different. And so, yes, they might not understand all the nuances of that person's culture, but chances are they'll know the questions to ask because they themselves have been part of a minority group. And so, do you want to add to that, Kim? I feel I'm stumbling a little bit over an answer. Because Aboriginal liaison officers, peer navigators, they hold a particular space, because people often say they would like to have an Aboriginal and Torres Strait Islander person in the hospital, in the space when they go there. It's important that there's that. It doesn't necessarily need to be someone from their own community.
No, it doesn't necessarily have to be someone from their own community, because that would be impractical. It's important to make sure that there are Aboriginal people, doesn't matter where they're from, who have lived experience of the kidney care journey from start to finish, their lived experience, so that they can explain to the patient who's come in, and they can explain to the patient in a way that they understand. So it could be something as simple as demystifying the medical jargon. It could be something as simple as, look, brother, this is what I had to do to prepare myself for a transplant. So it's like with, let me give you another example. If the tables were turned and there were Aboriginal and Torres Strait Islander people all in there, and we were the health professionals, and we were there providing services for non-Aboriginal people, or let's just say for Eurocentric people, and all you saw was black and brown faces, wouldn't you feel a little bit uncomfortable? So
I think this diagram in some ways is kind of looking at some of this about if there's people who are coming from Aboriginal and Torres Strait Islander background who at home and in their lives are much more involved with collective decision making and all those sort of connections, then for that person coming in, they might go, this person might understand in a way that maybe the white nurse doesn't.
And it comes back down to the history and the colonisation of this country, the distrust that is intergenerational. How can we have that conversation? How can we have these conversations at a national level as well?
Hey guys, we've just got a question online. So they just started off by saying, this is fabulous work and so pleased to hear about the project. And then the question is, how do you manage research timelines and deadlines in a study such as this when the peers themselves are not well?
Yeah, that's the challenging bit. That's quite challenging. We have an amazing team with research background, research skills. It's not an easy thing to manage because we certainly have to. There's a lot of behind the scene work that we do to make those deadlines. But I guess one of the things that's worked for us is that we have an amazing, just to give you an example, we have an amazing staff member who is all over ethics and all over our reports and all over the timelines that we need to respond to. And so that's her expertise. That's when we need to do reports, we need to make sure that we're on task. That's who we go to, and she's sitting right here. So that's probably one example.
And I think the other thing is, and what we've learned is, rather than having one or two people who will be involved in something, we have a reference group of 10. And there's a reason for that, and we wrote it into the NHMRC grant. So we wrote into the grant that we needed a large pool of people because we know that some people will be unwell or unavailable at any given time. So that when the action team are working with someone, instead of us saying there'll be this person and this person, we might say, there will be a couple of action team members or a couple of reference team members who will be there. And then there's that flexibility within the team about who is available, who is well. If someone was lined up to do it and then they ended up in hospital, who else can step in? And we do a lot of that. We're quite agile and flexible because we need to be. Also, that balance between when someone is unwell and they're in hospital, do they still want to be meaningfully involved? So we have held reference group meetings in the Royal Adelaide Hospital in the renal unit because someone happened to be admitted, but they still really, really, really wanted to be involved. So we take the meeting to them. And then we had other people who will sign themselves, who will say, okay, I'm taking leave, I have an important meeting. And they might appear with a renal nurse, or they'll come out of rehabilitation and then catch a cab and come for the meeting and go back. So for the people involved, often that's been a really important part for them. They will let us know whether they want to be involved or not, and whether that's something that's healthy for them or not at the time.
And also for the people involved, prior to action, there wasn't a place where they could meet other Aboriginal and Torres Strait Islander people who were going through similar things to themselves. So when we do have our reference team meetings, the first Thursday of each month, it's well attended. It's a social outing for members. They get to actually speak to each other and learn from each other's journeys and share information and knowledge. For example, one of our members is a grandmother, 5 children, had a transplant 7 years ago. Is a school teacher. She has a Masters of Teaching Indigenous Languages from Sydney University. She is all over writing about her journey, and also to creating resources. So, for example, a criteria for medication. So not only is it a social space for people to meet, but also it's a place where we can create the resources that patients and families need, and in an Aboriginal and Torres Strait Islander way, less clinical and practical to them. Sorry, love.
We've got one more question just at the back here, and then we've got another question down the front with the man in blue here.
Hi, thanks so much for sharing your experience today, considering how much you've gone through as well. So I'm coming today as a uni student who's lucky enough to help run the Adelaide Uni Rural Health Alliance that you guys mentioned. So for the Yalada Kidney Festival that we run every year, a lot of us don't come from Indigenous backgrounds, and I was just wondering if you would have any tips for how we can really make the trip more effective within the community. Yeah.
You've just been to that, haven't you?
Yeah, so one of the things that they did this last year was there was a couple of things. One was having some cultural safety training beforehand with Kim Thomas, who's an Aboriginal man from Port Augusta, and I think the students found that really helpful. And also Rani Lester joined us from Port Augusta. We actually drove across from Adelaide to Yalata so people could get a sense of distance. And so Rani was on the bus, and there were lots of conversations on the way. And then each morning and each night, we would have a round circle discussion. Everyone would come together and they would talk things through. So I think that critical reflection, that discussion, is the things that really value added, as well as doing some thinking and training before people went there. Does that answer your question? We can talk more later.
Come see us.
Yeah.
G'day, how you going, guys? My name's Parry Aegis. Couple of comments for you. The first one is your project is looking at the human side of the Aboriginal people and their connection to themselves and to a place and to the issues that they're facing and the reasons why they're coming together in a place to be together. Your research hasn't talked much about the thing called racism. Why are Aboriginal people coming together when they could use the general system? That's the first thing. So if you can answer that question, it'll be great. Second question is, up there on the dot point in the right-hand circle, from our point of view, or my point of view, you see this thing called separation of body parts, minds and spirit. Okay, so we've got somebody with a kidney problem, but they've got several other types of issues. Is your research connecting those several other perspectives with that person who's got the kidney and the deliverer of those services to the person who's got the kidney is also explaining their perspective per that body part, per that person with the kidney? That means several experts are actually visiting one person. Now, if we apply that in a university learning, how many schools do we have that are teaching several body parts but don't talk to each other, don't engage with each other, but when they leave the university with their degree, they're expected to continue that sort of framing, and then the only time it comes together when when a person is in the hospital, and several of those body parts will then come and visit that person on that particular floor to deal with that situation. How do we actually transfer the knowledge that you're learning from here to those other several body parts who are actually delivering those body parts, delivering services to those body parts, so that one individual can understand the impact on their body and the rationale behind why they're in that situation? So if you can answer those two questions, the first question should be able to give an answer to the person who's raised the issue about why Aboriginal people want to stick together, and you haven't given answers to the reasons why people are wanting to stick together and not actually be part of a wider system.
So let me see if I can answer that, Parry. Often when we have collaborations, it's important for Aboriginal and Torres Strait Islander people to actually have the space to talk the way they wanted to discuss things, to resolve issues that may happen in a collaboration or partnership. That doesn't often happen very often because we're needing to build the workforce to have more Aboriginal and Torres Strait Islander people working in hospitals as medical doctors, as medical staff, as Aboriginal health practitioners. It was important when we began writing the Working Together Agreement, which came from the reference team, the importance of having that black space, because it very rarely happens in the mainstream health services. And if it was to happen and it is vocalised, it's seen as reverse racism. So firstly, that's why it's important to have that space where Aboriginal and Torres Strait Islander people can feel safe and comfortable amongst themselves and amongst supportive allies. It is sad to say that that's how it is at the moment. The CARI guidelines took a long time of deliberations to write. It took a long time on colleagues' parts as a part of the committee to come up with the CARI guidelines, because the pushback from white health professionals, and I'm just going to be straight up, was that they didn't want to have the term racism or racist systems language in in the guidelines. So those guidelines took about 5 years on and off of pushback from people who really were pushing to have the R word, racism, systemic racism, in the guidelines, and that took 5 years of toing and froing. And Janet could probably expand on that, because God love her, she was one of them who was in that group. Also Samantha Bateman and others. So we are certainly trying to address racism, and that's an example of how long that took, because we wanted to put the R word in the guidelines.
And probably, you know, we're not having open discussions about racism in the way we could in the health system. I think we're still trying to work with people to get them over the line. As Kim said, it did take us 5 years to flip this one on the head and go, actually guys, before you start talking about risk factors, you've got to deal with all this stuff first. So yeah, you're right, it is something. The cultural bias report we really struggled with. We're going, cultural bias, why don't you just call it racism? Government funding, where we were there, what we could get at that time, it was a vehicle we could use. So we made a pragmatic decision about that. But yes, we should just be talking about racism. But sometimes the door's shut and we can't get further. So like we said, we don't always get it right. We're just trying to work with what we've got.
And the cultural safety report, we were approached to write a report on cultural safety and what it was, because cultural bias, sorry. We were approached to write a report on cultural bias, and when we started to talk about it and the language, we thought, well, isn't that just racism? It's just a warm and fuzzy word to kind of express, you know, racism. So we took on that challenge and partnered with the Lowitch Institute to write that report. But there was also pushback in writing that report in terms of the process we wanted to use from health professionals who have sat in those positions of power, mostly old white men, for a long time. We had lots of pushback because we wanted to make sure we include the grey literature, the reports from Aboriginal and community-controlled health organisations and other organisations, but we also wanted to include as part of, and to elevate the voices of renal patients, was to include their voices. So we wanted to include the yarning sessions that we had, as well as the literature and the things that were already written there.
The other good thing is we've actually brought people along with us. So some of these people now are the best allies who are really getting there and doing some great work. So from where we started to where we are now, there's been movement. So that's been a really good thing, and it has led to better kidney care for people. So, yeah.
Can you answer the question about the body parts?
The body parts.
Yes,
okay.
I'm happy to answer the question about the body parts. So what generally happens with a lot of funding, medical funding, it goes to the other end. It goes to the biomedical end, to develop new medicines to keep people living longer. It's based on a biomedical definition of health, which is the body parts. Whereas if you're looking at the holistic view of health, it takes into account the spiritual, the physical, the spiritual, physical, and the whole person. So in 1989, the Aboriginal health strategy was certainly developed to push back against definitions that broke people up into parts. So it's interesting that that's also what is continued to be taught. I think we need more conversations about the whole person, and in particular, we need to look at ensuring that the definition of health is a socio-environmental inclusive definition of health. And I firmly believe that if that definition was up the front in every hospital that you walked into, it may get people to think, those people who have access to, who control the funding, it may get them to actually think about treating the whole patient.
And just to add to that, just briefly, when we're looking at the health journey mapping, we bring together all the different things that are important for the person. What are their priorities? What's happening with the different parts of the health system, but try and bring it together. And we do incorporate that into our teaching of nursing students so that they can think about people when we do a lot around person-centred care and patient-centred care. What is it for this person, and how do we ensure care is more joined up and coordinated rather than separated? So there's a lot more work to do, but there is work that we're doing towards that as well.
Can I just make one more comment?
Sure. One more comment and then we have to wrap it up there, so make it very, very quick if you can.
Just wanted to give a perspective. I run, I got a contract with Saaland to run cultural training. So this is a body part concept. So here I'm giving historical history, impact, etc., to a group of people who come from different body parts of the health system. And the discussion that we're having is, why wasn't I taught this before? Why wasn't we given this information before? Why wasn't we part of this process? And these are people that come from the ED section, come from the nose and throat, comes from other parts of the health system. Even though, in this particular instance, we're talking about the kidney, the person who's got kidney problems may have all these other problems. But in terms of me doing training with the health professionals for the Saaland region, I'm getting over 400 odd people coming to our workshops from different backgrounds in the health who are saying, I want to know something about Aboriginal people. And so if I'm going to be delivering services to an Aboriginal person, I need to know what is the background of that Aboriginal person, where they come from, who they come from, and so on, and why are they scared to talk to me as a health professional. So our job is to help that smooth transition. And in this perspective here is, we've got body parts that don't talk to each other, and the main cause of an Aboriginal person having disease, a kidney problem, may be associated with the other body parts. And so how is your research in making sure that those other body parts get to that Aboriginal person? Not just focus on the kidney problem itself and the cultural, the relationship of the culture of that person and their connection and how they communicate with each other to deal with a system that doesn't want to recognise that.
Yeah, it's a much bigger conversation that would be good to have later.
I'm sorry, we're really going to have to finish it up there, but it's really important that we keep having these conversations. They're very important. So if you can please join me once again in thanking our two fantastic speakers. And thanks to all of you for attending tonight and for your fantastic questions. Don't forget to sign up to our Research Tuesday mailing list to get all the information on our future events. And thank you for tuning in once again. Good night, everyone.